It's, so I am a neuropsychologist, and just so everybody knows and we're all on the same page, so my background is specifically related to mental health and cognitive functioning, and certainly the brain aspects of functional seizures or psychogenic non-epileptic seizures. I'm not a neurologist, however, so I don't directly diagnose the seizures. As we'll talk about, it takes a village or a team of providers with different types of expertise, and so my expertise is not about diagnosis, and I don't prescribe medications, but it's a lot about mental health and thinking and the experience of having the seizures and that kind of thing. So. Um, a few disclosures. I have a podcast and a book that's related to tonight's talk, and I work at the Providence VA. So I've got a little bit of research funding from them. I like to start talks like this by acknowledging and thanking all the people who I work with. I am so lucky and incredibly grateful to work with colleagues, friends, mentors, trainees, all the people on this slide and many others. We work together on research and helping people with functional seizures. And so anything I talk about tonight, any work I've done, a lot of kudos to great people that I work with. So I'd like to give you a brief roadmap on where we're going and how the talk is organized. First, I'm going to talk a little bit about terminology and classification, which I'm sure does not sound incredibly exciting, but it is important. There's a lot of words and terms that come up related to functional seizures or psychogenic non-epileptic seizures. And so I want to make sure we're all on the same page about what we mean about these things. So here are a few of the specific areas within that I'll talk about. And then I'm going to take a step back and talk about functional neurological disorder. I'm not sure how many folks here tonight have run into this term, functional neurological disorder. If you have, great. If not, that's okay too. I think I'll explain when we get there. There's some good reasons when we're thinking about psychogenic non-epileptic seizures or functional seizures to understand the bigger context, the parent or umbrella concept, which is functional neurological disorder. So within that, we'll talk about what this is, how it relates to the seizures, a little bit about what's going on in the brain. I'm going to emphasize throughout the talk that these conditions, such as the seizures, are not faked. They're very real, about some of the stigma and challenges that many people with these seizures and related conditions have faced, and we'll end with treatments and resources. So to start, what should we call these seizures? These seizures are not epilepsy or something else. I'm calling them functional seizures, but I think many people call them psychogenic non-epileptic seizures or PNES. Here's a brief list of a few other terms that are sometimes used to describe them. To give you a sense as to some of the confusion and some of the just varied terminology here, there was one research study of 11 patients, and they found these were patients who went to the emergency department because of the seizures. The researchers found that in the just 11 people, doctors and providers had used 48 different terms to refer to the same thing, to refer to the seizures. So it's kind of a mess. There's a lot of different terms floating around out there, and it makes it hard to know what a doctor might be talking about at any particular point in time. So keep in mind that there's no ground truth here. There's no one single answer about what to call these seizures that is absolutely right. However, in my opinion, a few of them are wrong. Types of words that suggest that the seizures are not real, and words that suggest that there's something wrong with the person who has the seizures or that they're deficient somehow, like hysteria, pseudo seizure. I think those terms don't make sense. And luckily, over time, fewer and fewer providers and people use those types of words to describe the seizures. As we'll talk about, these seizures are very real and valid and can cause a lot of suffering, just like epilepsy. So I'm going to call them functional seizures. But aside from the derogatory terms, any other term we want to use, like PNES, is just fine with me. And those are synonyms, meaning the exact same thing. So I want to talk about 3 different types of seizures. If we take a step back, and if we know that somebody had a seizure, but we don't know anything else, there's one of 3 potential groups or categories that the seizure could be. Many people know about epilepsy, and that's one of them, but there are these 2 other categories. So we'll start with epilepsy. Epilepsy is caused by abnormal neuronal or brain cell firing. The brain cells are not firing the way they should be. Functional seizures, the focus of today's talk, and I'll get a bit more into this later, are caused by problems with brain cells communicating with each other in networks. And then there's one other type that we won't talk more about today called physiologic non-epileptic seizures. These are due to an imbalance in the body, such as if somebody has low sodium or they're withdrawing from alcohol, they can have a one-time seizure of this type. So, as I mentioned, importantly, because this hasn't been appreciated in the past, all 3 are equally real seizures. We can use that word, seizure, to describe them. But just like, we have different flavors of ice cream, different dog breeds, they're different types of seizures. When thinking about comparing functional seizures to epilepsy, this comes up a lot. An analogy I like to use is icebergs. So functional seizures and epilepsy can look very similar if we were to observe somebody have a seizure, and I am not highly trained in diagnosing seizures, as I mentioned. So those 2 seizures can look very similar. Imagine what's called a tonic-clonic seizure, which is the shaking that you might see in TV shows and movies. Not all seizures are like that, but if you imagine a seizure like that, if you just watch it, see it happen, epilepsy and functional seizures, they can look almost the same, very, very similar. It's almost like you see 2 relatively small pieces of ice above the water, and it looks like they're mostly similar. The reason why we call these things different words is because functional seizures and epilepsy underneath the surface, meaning in the brain, are very different. Just like the contours of icebergs under the water are extremely different, even if you sort of come across 2 of them and it might look like they're pretty similar. If you dig deeper, then you'll find big differences. So in the brain, functional seizures and epilepsy, very different, even if it doesn't seem that way. So now that we've talked about just a few key aspects of the seizures themselves, I want to do something a little bit unconventional and take a step back and talk about functional neurological disorders. The reason why I want to talk about this other term is because, just like the slide shows, functional seizures are one type of functional neurological disorder. So this FND is the parent category. It's a superordinate group. And then there's a bunch of different types of functional neurological disorders. We'll focus on the seizures, but just so you know, there's other related types like functional movement disorders, functional cognitive disorder, and these things are all highly related. They might look different on the surface. Like a seizure looks different from, this might be like a tremor or problems with gait or walking, almost like it could look like Parkinson's disease. So looking at 2 people, one who has the seizures and one who has the movement disorder, could seem very different, but what's going on in the brain, unlike with epilepsy, what's going on in the brain seems quite similar in functional seizures and functional movement disorders, because they're all just different variants on the theme of functional neurological disorders. So during the talk, I'm going to say a lot about FNDs, or functional neurological disorders, and it all applies directly to the seizures and to these sort of sibling categories as well. When appropriate, I'll give examples that are very specific to seizures, but I want to make sure we're all on the same page, and I try not to introduce too many different terms. There tends to be a lot that we have in medicine and psychology, and sometimes too many. But this one, FNDs, I think is important, and so we'll talk a lot about that today. Background information about FNDs. What this is, this disorder, this condition, it means that somebody has neurological signs and symptoms, such as seizure, tremor, or memory loss, that's due to problems with how brain networks are functioning. And this is different from what we might call conventional or traditional neurological disorders, such as stroke or epilepsy or traumatic brain injury, where in those conditions, we can use our medical tools like a brain scan, and we can see structural damage to the brain. In FNDs, we, at least with our current technology, we can't see the structural damage, but the functional damage is there, and that's what's causing the symptoms. FNDs have been recognized for many, many years, hundreds, maybe thousands. There's some suggestion that people in ancient Egypt recognized these disorders and wrote about them. They're also present all over the world in cultures and countries. It's not specific to the US or to North America. They're also not rare. They're actually functional neurological disorders in general. One large study suggested are the second most common reason why people visit a neurologist. Headaches are the first most common reason, and functional neurological disorders, including the seizures, are the second most common reason. So not nearly as rare as some people have thought. If we think about the seizures specifically, there was one study estimating that over 350,000 Americans have these seizures. And if we look at public health, like stepping back and looking at big populations of people and the burden and disability and suffering caused by functional seizures, a lot of research suggests that it rivals more common, well-known neurological conditions such as epilepsy. So it's an area where I think we need more attention and better public health messaging. One good analogy to start to wrap your head around functional neurological disorders, including the seizures, is this software hardware analogy. So here, imagine that the brain is a computer. What happens in the conventional diseases like stroke and Alzheimer's disease is that there's damage to the computer's hardware. So, you come home and to your computer and the screen is cracked or keys are missing from the keyboard. It's pretty easy to tell something's wrong. And that's analogous to somebody with stroke. They get a brain scan and there's clearly a big lesion that the doctors can see. And so it's sort of a more straightforward picture to understand. With FNDs, the hardware is intact. So it looks like a brand new computer. It looks like it's functioning just fine, but the software programming is damaged. And so a computer that looks like this, if it has a virus and or for other reasons, if the software is damaged, it might not work very well at all. But it's been tough sometimes for doctors and other medical providers to appreciate that because, if this is their brain scan and it looks pristine, they don't see a lesion or damage. Sometimes they might think, oh, there's nothing wrong. There, as I mentioned, even though it's software, not hardware for FNDs, they can still cause equal amounts of symptoms and disability and low quality of life. It can be really tough to have and to manage. So you might wonder, there are these things, FNDs, such as the seizures, who can develop them? They're most common in younger adults, people in their 20s and 30s and 40s, more common in women, and more common in people who have prior mental health histories. depression, anxiety, trauma, OCD, things like that. But importantly, an FND can occur in people of any age, from children through older adults, in people of any sexual orientation or gender identity, and as I mentioned earlier, across the world, across countries, racial, ethnic backgrounds. So they're not limited to any one group. There's a lot of interest from researchers in what is going on in the brain in FNDs. And this slide is very complex. I won't get into it in detail, but one way to think about sort of summarizing what we're learning about FNDs in the brain is if you think about how the brain is structured and organized. So in the brain, we have the brain cells called neurons, which tend to cluster together near each other. We might call those clusters cities. And then the cities are connected to each other via cable work, like roads, how roads connect cities. If it's a stroke, the city itself is highly damaged, which is easily visible. With FNDs, it's more like the cities, when they try to communicate to each other, when these clusters of neurons are sending signals to one another, the signals are not arriving. The communication isn't happening for one reason or another that we're still trying to figure out. Though the roads, the cable work is damaged, and so it causes a lot of symptoms and dysfunction. There has been a pretty big shift and change in a positive direction regarding FNDs in recent years, which is that there's been a better appreciation that we can diagnose them and we can figure out if someone has an FND, such as functional seizures, using positive signs, meaning it's not just the result of ruling everything else out. This is what used to happen with FNDs. It still may happen sometimes. My hope is that we're moving away from this, but the rule out model is basically, I have seizures, I go to the doctor, they run a bunch of medical tests on me, they do EEG, they do a brain scan, they take blood work, and they don't find anything. And when they rule everything else out, they throw up their hands and say, well, it must be an FND because we ruled everything else out. That's not the best way to diagnose any problem. You can imagine if that's how we diagnosed brain tumors. If somebody had headaches and confusion and dizziness and they went in and all the tests were negative, the doctors threw up their hands and said, well, it must be a brain tumor, so we'll give you radiation and surgery. That would not be okay. We should be able to show positive signs. There should be a test that's better than that can identify exactly what is going on, not just it's not there. And so we have developed good positive signs for diagnosing FNDs, including the seizures, that are accurate, reliable, and stable over time. And each type of FND, the seizures, the movement disorders, the cognitive disorder, each type has its own unique strategy for diagnosis. So, for example, for functional seizures, the gold standard, the best way to diagnose the seizures is long-term video EEG monitoring. And this often takes place in a highly specialized medical unit called an epilepsy monitoring unit. Sometimes it can take place at home. There are ambulatory systems, but essentially what happens with the video EEG monitoring is that there's two pieces of information that the neurologist needs to have in order to know it's functional seizures. First, they need to know what's going on in the brain. That's the EEG, the electrode cap that the person is wearing. And by the way, the electrode cap is harmless. It's passively recording brain activity. So you've got the EEG, but then the second part, which is really important, is that person's activity, the seizure behavior, needs to be videotaped. The reason for this is what needs to happen is when the person has the seizure, however that looks, it could be a staring spell or the jerking movements or something else, we need to view the brain waves and then link the brain waves to exactly what the seizure looks like, it's called seizure semiology, like how are the person's arms moving? How is their body moving? Are their eyes open or closed, mouth open or closed? All that needs to be linked to the brain waves in time. So at each moment in time, you know how the person was acting, like what the seizure was looking like, and what's happening in the brain. That allows the neurologist to identify if it's epilepsy caused. There are certain patterns of brain waves that are very specific to epilepsy. If it's not those brain waves, then there are subtle clues and hints from what the seizures look like that can allow us to make a very reliable and confident diagnosis of functional seizures. I had mentioned earlier this important point that FNDs, including the seizures, are not faked. So this has been a big area of confusion in the medical system for a long time. Unfortunately, a lot of patients have suffered for it. FNDs have been confused with faking, which is sometimes also called feigning or malingering. In other words, doctors have mistakenly thought that someone who has an FND is just pretending, just making up their symptoms in order to get attention or disability payments or something like that. And with good scientific research over time, we've come to learn FNDs are very distinct and different from faking. We would say the symptoms are genuinely experienced, just like in any other disease or disorder. A few little tidbits of evidence that these scientists talk about in their article. The evidence for this comes from different angles. So there's been research in large population studies across cultures, across time periods. And essentially what's found is that no matter what culture we're looking at or time period, there are similarities in what the symptoms look like a functional seizure, whether it happens in the US or India or South America, looks similar. And across time periods, these FND symptoms are manifesting in similar ways. That's not what we would expect if people were faking. If people were faking, they would just make up whatever it is that comes to their mind, that they watched a movie and saw what a seizure looked like, and they would try to emulate that. What happens with functional seizures is that there's this common thread, and the seizures will always look similar, just like how somebody has Parkinson's disease, their tremor will look similar to somebody else who has Parkinson's disease, their tremor, because what's going on in the brain networks causing that symptom are overlapping. So putting together all this evidence, there's this very strong case, and over time, better appreciation for the fact that FNDs are not faked. Of course, any person could tend to have a disease, and somebody who's depressed could pretend to have a condition, or somebody who's well could pretend, but doctors are starting to appreciate more so that we need to take these FNDs very seriously, just as seriously as we do epilepsy and Alzheimer's and cancer and everything else. One more example of some of the misunderstandings related to FNDs is a research study that looked at 13 news stories of so-called medical mysteries. This is a bit like if you've ever seen any of the TV shows that talk about these very unusual or rare or freakish medical situations and medical mysteries that the doctors couldn't figure out. That certainly happens, but in this research study, they found that these so-called medical mysteries, at least a good proportion of them, were likely functional neurological disorders, which just goes to show that even though I've mentioned there's been progress, there still continues to be this sort of misunderstanding. I think what happens is, if somebody has a seizure, but it's not epilepsy, a lot of folks just haven't heard about functional seizures. They didn't know that there was another possibility. So if somebody's having these seizures, but they do the EEG and it's not epilepsy, then it's a medical mystery. What is it? It's this bizarre thing. And so I think this really points to the need for, better messaging and better education and understanding that FNDs are real and common. unfortunately, what I've mentioned thus far, that all these misunderstandings have led to a lot of stigma that's been reported by people with FNDs. So when I say stigma, I'm thinking of these negative social attitudes that people have based on the characteristic of somebody. And stigma really relates to perceived deficiencies that the general public believes somebody has. And people with FNDs have reported experiencing a lot of the stigma. They've talked about, and so these are research studies where people who have these conditions are interviewed and asked questions and asked to describe their experiences. They describe feeling illegitimate, like they're faking, like their disorder is not as important as something else, such as stroke or epilepsy. And some of them describe feeling excluded from their social groups or rejected and experiencing discrimination. So I thought it might be helpful along those lines to include a few quotes. So these are direct quotes that people who have FNDs, including the seizures, have said. Give you just a moment to take a look at these. The top row really focuses on misdiagnosis and not being believed, being told that you're faking the symptoms. On the bottom row, those quotes focus a bit more on the impact that some people describe this having on their identity, their sense of self, and just how hard this can be. So it's not all doom and gloom, though. From the perspective of the healthcare provider, I want to say that I think doctors caring for people who have functional seizures and other FNDs are not just ignorant or uncaring, or it's not that they don't care about these patients. I hope so, because I'm one of these providers. What happens to cause this is a lot of researchers, doctors, nurses, psychologists struggle with this too. They talk about wanting to do better, wanting to provide better care, but having a lot of uncertainty about the diagnosis. They weren't trained in this. They were trained really well in stroke and Parkinson's and Alzheimer's and all the more common or more well-known conditions I've been mentioning, but nobody told them how to recognize FNDs. And so it's confusing and they sometimes avoid it. And there's this frustration that comes with this. So there are pretty clear solutions. We need better training of doctors and other providers, just psychologists. And so this is something I'm working on in my field of neuropsychology, is that we should be training our people better in this from the start so that they can do better by their patients. And then related to the news stories I mentioned a minute ago, we should have better messaging about this in the general public so that people don't mistake FNDs for some rare medical mystery. There's a topic that I haven't touched on yet before we get into some of the treatments that I think will be useful, which is co-occurring conditions. So here we're thinking about other disorders or symptoms that people who have FNDs commonly struggle with. For many people with FNDs, they have their symptom, like they have the seizures, but it's not just the seizures. There are other things going on. They might, because of the seizures or because of another reason, they might feel very anxious a lot of the time, and that might limit their ability to get out of the house and to socialize and to work. And traumatic brain injury, like concussion, is common. A lot of people with functional seizures also have epilepsy. They can go together. There's also a lot of physical illnesses that happen a lot, like COVID-19 or high blood sugar, hypertension, high cholesterol. A lot of other things tend to come with this. We don't always know which one caused which. It might be that the FNDs, the seizures, cause anxiety or cause trouble sleeping because I'm worried about my seizure tomorrow, having a seizure tomorrow, so I can't sleep. Sometimes there are theories that having trauma in one's life might make having the seizures or the other FNDs more likely. That's possible. Often we don't know what caused what, but regardless, these other co-occurring conditions are tough and just add to the burden of the illness. There's a few caveats though. Although most people who have FNDs have at least one of these other things, not everybody does. Just because somebody has an FND doesn't mean they must have all these other bubbles. Also, there's no one doctor or any one human being who has expertise in all these different conditions. And this means that we really need a team of doctors who are trained in different areas to work together. Some doctors are experts in sleep, others are experts in depression and anxiety, and there's medical doctors who treat physical conditions. And so if there's a lot going on for the person, if you're struggling with a lot of different things, it might make sense to work with a group of doctors who are communicating with one another and who can come up with a plan to best target these various conditions. When thinking about treatment, most of the time, different disorders have different treatments. So treatment for pain is likely going to be quite different from a treatment for PTSD, different from treatment from substance use. So this means that assessment or finding out what's going on, like what specifically are my symptoms, that's really important, because once we figure out what all the other co-occurring conditions are, that can guide and provide a pathway to which treatments will work better. So this assessment might be called a neuropsychiatric assessment or a neuropsychological assessment. Basically, it's very holistic, where the doctor learns a lot about you, the patient, and the family, and what's going on, the different symptoms and the timelines, and tries to make some sense of it so that we can recommend the best treatments. One more comment about symptoms. One of those little bubbles referred to problems with cognitive functioning, and these are quite common in people who have FNDs, including the seizures. So here we're thinking about problems with thinking and memory, like trouble concentrating, trouble finding words, short-term memory loss, trouble multitasking. In surveys of people with FNDs, roughly 85% of them report at least some of these symptoms. So not all, and maybe, it's not the case that this always happens, but these are quite common. And when they do happen, memory loss, slowed thinking, trouble finding words, it can often interfere with things like work and school and remembering a grocery list and remembering a medication list. So this is an area where I think if these things are going on, it's really good to talk to a doctor about it. And I'll mention in a minute what are the things that can help. So this is my favorite part of the talk, because it's not just what's wrong, it's what can be done and how we can improve. And there is a lot of hope these days, and there are different options that can help with the seizures. For the next slide or two, I'm really going to focus on the seizures specifically and which treatments are best. So the number one recommendation, the first line treatment, is psychotherapy. And this is especially useful if it's with a skilled clinician, somebody who has a lot of experience. Just a few examples of things that might happen in this type of psychotherapy is it can help us gain insight into what's going on in our minds. It can help with identifying triggers for seizures and then making a plan to avoid those triggers. It can help with coping with stressful situations, with regulating emotions. A lot of tools and techniques that can help reduce the frequency of the seizures and often help improve quality of life. That's what we're thinking about with the therapy, is how can I help this person improve their life and whatever their goals are. There's a lot of different orientations or types of therapy that can work. I've listed a few of them here. there's one in particular, that type of therapy that has been specifically designed for people with seizures, called neurobehavioral therapy. So this is a psychotherapy that uses all the tools of more well-known therapies such as CBT, cognitive behavioral therapy. It uses those tools, but it's really specifically tailored for people who have seizures. It can work for functional seizures or epilepsy. So if this is something for you or somebody you know, and you're looking to consider, psychotherapy, I would suggest asking your doctor about this. I'm happy to share these slides afterwards so you can have the name of it, to see if there's any people in your area who are trained in it, like a therapist who's been trained in this, or if a therapist would be willing to get trained in it, as trainings are offered. I think other treatments can work very well, but if it were my relative or if somebody was asking me, I'd say, if the treatment is designed specifically for seizures, then there's really unique aspects of the seizures themselves that can be accounted for during that protocol, during the treatment. And so I think targeting with an approach like this probably has the best chance of helping. And a few minutes ago, I had mentioned these co-occurring conditions. In addition to treating the seizures themselves, a lot of people wonder, should I do something about my anxiety or my insomnia, my cognitive problems? And this is something to think about. So each different type of symptom has different interventions, different options that can help. For mental health conditions like depression and anxiety and PTSD, there are different types of psychotherapy, not exactly the same as for the seizures, similar but different, that can help. Sometimes medications, breathing techniques, exercise or physical activity can be helpful. For cognitive problems, your doctor might recommend a neuropsychological evaluation, which is testing thinking and memory to really figure out strengths and weaknesses. And then importantly, recommendations to improve brain health, and sometimes something called cognitive rehabilitation, which is all about teaching different strategies and tools to help with memory and to help with all those other aspects of thinking. There's different treatments specifically for insomnia, listed a few here. For physical health symptoms, that's a very broad category. It depends on what it is. It could be physical therapy, or there could be medications or other medical treatments that can be helpful. For epilepsy or other neurological symptoms like headaches and dizziness, it might be useful to see a neurologist. And often neurologists are the people who have initially diagnosed the functional seizures. So if you are someone with functional seizures or someone who has them, there's a decent chance that you might already be connected with a neurologist. And these are not exhaustive. These are just a few examples. Also, there are a lot of great organizations and groups who are very interested in helping people who have FNDs, including seizures. So I mentioned I'm glad to share these slides. I've included links to websites from some of these organizations. And if you're wondering what you might get there, these groups provide great education about FNDs, even beyond what we can get into tonight in an hour. There's links to support groups so you can connect with other people who have FNDs and who've struggled with them and who have their own stories to share that can be really helpful, so as to not feel isolated. There's support groups for caregivers, which is very important if you're interested in getting involved in something like fundraisers, advocacy. There's some information about finding a healthcare provider near you if you're looking for that, connections to research studies. All of that is available. And as I get ready to wrap up, there's also a few webinars or podcasts that you might check out. These are all freely available if you want to watch them. I think of my role tonight as, talking generally about FNDs and functional seizures, and so I'm happy to provide general thoughts and advice. Of course, I'm not um, the doctor or provider for anyone here, but if anyone has any questions more generally, I'm happy to get into those. Also, want to say that I'm very grateful that you all invited me to speak to you. I know we're all busy with our lives. There's a lot of things we could be doing. So I'm always incredibly happy and grateful to be invited to something like this. So thanks for your time and attention. I'm happy to chat if there are any questions.
Thank you so much, Dr. Van Patten, for spending your night with us tonight. We so appreciate it. So now we're going to open the floor up to questions. If you have a question for Dr. Van Patten, you can just unmute yourself, or you can even put it in the chat. So we're happy to do that as well. So a question just came up. Are there specific neuropsychological test findings or like a common profile that helps differentiate between PNES and epilepsy?
That is such a good question. A lot of researchers have wondered that very same thing. There's been a lot of work on that question. Is there a pattern of findings, memory, attention, processing speed that can tell us if it's one seizure type or the other? There's been research on this for decades, and the short answer is no. There's no specific cognitive profile that you get from cognitive testing that could tell you with confidence this is PNES or epilepsy. So the thing to do to figure out which seizure type it is to get that long-term video EEG monitoring, and then the cognitive testing can do something else. The purpose of the cognitive testing, instead of diagnosing the seizures, the cognitive testing generally happens afterwards. So you've been diagnosed with PNES, so for example, and you notice problems with thinking and memory in your life. It might be useful to get that cognitive testing, and then the neuropsychologist can understand, based on the test results and based on what you tell them, like these are the areas that are a real struggle. This is where the problem is. And then they can recommend certain interventions, like I mentioned, cognitive rehabilitation. They can recommend specific treatment that can focus on the area where you're struggling, like short-term memory loss, but could also capitalize on your strengths. Maybe, language skills are a particular strength of yours. And so really zero in on helping with that issue with an eye toward whatever your goals are, like, going back to work or doing better in school or what have you. So I would say the neuropsych happens after the diagnosis.
Thank you so much. We do have another question that's come up. Could you say more about locating providers who already are specialty trained for neurobehavioral therapy, or where to send providers to get that training? Connecting these patients with the appropriate follow-up care is a challenge in a state like Maine, where I work with this patient population. Thank you very much.
Yep. That question comes up a lot, and it is a work in progress. There's not thousands and thousands of providers trained in neurobehavioral therapy yet, unfortunately. One thing I'm happy to do is connect after tonight and send some links about upcoming trainings for the neurobehavioral therapy and resources, like when it does happen. One thing that has happened in the past 4 years or so is that there's more and more telehealth delivery of therapy in general, including neurobehavioral therapy, can be delivered over telehealth, which can help a lot for folks who are in an area that might not be next to a really big city and or might not be near people trained in neurobehavioral therapy. The geography isn't such a barrier anymore, because you can get connected with telehealth. So I'm happy afterwards. I don't have sort of off the top of my head the next trainings and when they're happening, but I'm happy to share that.
We also have, through the Epilepsy Foundation, through the Learning Portal, there's also a great on-demand training for therapists, for behavioral workers that is specifically for functional disorders. So I'm happy to send that information out as well, Lynn, when I email everybody after this training. And even if you're not someone that is a clinical person, it's sometimes, you don't have to be clinical in order to take that epilepsy learning portal on demand. It's all free. So I've taken it just to give me more information and become more familiar. So I definitely open that up to everybody. You don't have to have a clinical background to take these. It is for that person, but again, being able to do that yourself is perfectly fine. Are there any more questions at this time? We're happy to give more if needed. Well, with that being said, I want to thank Dr. Van Patten so much for being with us tonight. Oh, there's one more. Are the medication used to treat PNS the same as the medications used to treat epilepsy?
Another very good one. So no, if we're thinking about the medications that people with epilepsy take to help prevent the seizures, like an anti-seizure medication, someone with epilepsy takes this medication and it helps prevent the seizure from happening or reduce the chance that it'll happen. Those medications do not work for people with PNES. So people with PNES, there's no medication that prevents the functional seizures or PNES from happening. The thing that tends to work best for reducing the seizures is the psychotherapy. Sometimes people with PNES who also have something else, like if they also have depression or also have anxiety, there might be medications for that they're taking, but it's a key reason why we try to figure out what seizure type someone has, because if it's epilepsy, maybe medications help. Those same meds do not help someone with functional seizures, and the side effects can be damaging. So yeah, good question.
Question right under the wire. And there's one more. I have worked with several patients who have both epilepsy and PNES. Is this common? Is there a link or increased risk for someone to develop the other condition?
It's fairly common. And there's a lot of theorizing about this, about what the link might be and why it might be. It's not completely known. Sometimes people who have functional neurological disorders, if they've experienced like a conventional neurological disorder in their life a lot, like if a parent has had Parkinson's, they might develop a functional tremor. If they or someone they know has had epilepsy, they might be at greater risk to develop functional seizures. And we're not exactly sure why, but that happens fairly frequently.
Awesome. Well, thank you so much, Dr. Van Patten, for your time tonight. This recording will be emailed to everybody. Dr. Van Patten, I was actually asked a question about sharing your slide deck. Is that something you'd be willing to do with our families?
More than happy to.
Awesome. Thank you so much for spending the time with us tonight. Again, this is our actually last Wednesday webinar for the summer. We will be taking back up in the fall, so we look forward to having all of you guys back in the fall with a whole host of brand new topics. If you haven't checked out our YouTube channel, go ahead and just Google Epilepsy Foundation New England YouTube. All our recorded past webinars are in our YouTube channel, so please go ahead and visit us. But Dr. Van Patten, thank you again so much for volunteering to be our speaker tonight and spend our time with us. I truly, truly appreciate you being with us.
Thank you so much for having me. It's been great.
Awesome. Thank you, everybody. It was lovely seeing all of you, and you guys have a lovely night.